currently we are in the midst of COVID-19 pandemic, but our health minister has said that Malaysia will be moving into an endemic phase. What does that mean? What does endemic mean? And is this even normal?
Yeah, Joshua, but before I actually go into what the endemic actually means, but perhaps let me explain and differentiate a few terms that we often use rather interchangeably in our everyday conversation. And I think it's really important to understand what each of these terms actually mean. First of all, I think when we first heard about the epidemic, epidemics are essentially an actively spreading disease that affects a large number of people within a community, population, or region. And it usually indicates that the problem is out of control. The second, I think, term that we probably now hear a lot of it is pandemic, which is when an epidemic now spreads over multiple countries or continents. So if you can think about it, it's an epidemic with a passport. So essentially an epidemic that travels. And a global pandemic just means no country is escaping this epidemic, like what we have with COVID-19. And so when the minister says endemic, this does not mean that the disease is just disappearing. This means that the disease is still consistently present within a specific location. For instance, like what dengue is endemic in Malaysia. But the distinction that differentiates an endemic to an epidemic is that the problem now is under control. And a fourth term that you will be hearing when we go into endemic, and you probably have heard of, which is outbreak. And an outbreak is a greater than anticipated increase in the number of endemic cases, such as we hear of periodic dengue or typhoid outbreaks that we have in this country. Or an outbreak could also be a single case of a disease in a new area. Like, for example, when you hear of a case in Perlis or in the future Labuan, it's an outbreak. So an outbreak, if left unmitigated, it can also become an epidemic. And of course, if that epidemic unfortunately gets transmitted to other countries or other regions, then it becomes a pandemic. So it's really important to understand that, as we transition to this phase, the phases are actually quite fluid, and the diseases become more or less prevalent will determine which phase we are in. And over time, this is also going to be determined whether we have adequate treatment and control measures put in place. So the minister is absolutely right, looking at a lot of the recent trends, and especially in the Klang Valley, Selangor, and Kuala Lumpur, after the vaccination surge capacity initiative, we are seeing huge signs that if the current trends continue, COVID-19 will become endemic. And with a consistent increase in vaccination rates and other layers of public health measures, I'm confident that we will see a lowering of the symptomatic disease burden, a reduction in the ICU admissions, deaths, and stress on our health systems, and hopefully a generally better disease control. But we have to accept that there will be sporadic outbreaks, and if we fail to manage it well, and if there are emergence of more virulent strains, the risk is that these outbreaks might lead us to a return to an epidemic. But I think we have also learned a lot over the last 18 to 20 months that hopefully over time, with good control measures by everybody involved, including us, we hope that the number of positive cases will also reduce, and thus further reduce the risk of outbreaks. And perhaps we will get closer to that pre or post-COVID normal that we all can't wait to happen.
But, if COVID-19 does become endemic in Malaysia, could you just elaborate on what that would look like and what our daily life would also look like? Does this mean that for how long do we have to keep on the mask mandate, for example? Do we always have to wear the mask? Is there always going to be restrictions now when we're dining in? And is this a whole new normal because that COVID-19 is here to stay?
Yeah, and I think the key word here is when we talk about endemic, it's acknowledging that we are coexisting with this disease or virus. And more importantly, we know and take all the measures to ensure that the presence of the virus and disease in the population does not affect our existence, disproportionately like what it's doing now. It is most probably not going away anytime soon, and that's a reality that we all have to reconcile with. But we can certainly learn and live with it as productively and positively as we can. Although we cannot eliminate them from our environment, we know more about the disease now than ever before, and also the kind of behaviors and strategies to avoid them. And the key word here is our own individual and collective behavior, as well as the accompanying public health strategies, and of course, the science and technology innovations that we expect to see that's obviously going to transform the way we treat and manage the disease. But until we have the number of positive cases really down to the levels where the risk of infection is no longer omnipresent, we have to continue wearing masks. We have to reduce direct contacts through adequate physical distancing and really modify our lifestyle, such as reducing our indoor interactions. Think about how we have normalized wearing helmets or safety belts or washing our hands before we eat. Think about the first humans who started wearing clothes. I'm sure they found it a bit odd. But it's all about normalizing this culture out of necessity. And on top of that, we also need to enhance the ability to diagnose and report, in our country, so that each and every case is diagnosed and traced efficiently, so that we can quickly identify transmission networks, so that we can interrupt potential outbreaks that risk that epidemic. So it's only until we reduce the number of cases to a level, right, where the risk is no longer omnipresent, only then will these social restrictions be eased. I wish I can tell you when this is going to be happening, but I think we just have to be guided by the data that we actually see being reported every day. I do not think that anybody seeing that 20,000 cases is going to feel rather protected from the risk of infection. And over time, this is where the value of it being endemic comes. Over time, COVID-19 could become a disease that is first encountered in early childhood, when it would typically cause maybe some mild infections or none at all. But there will be some defense that will help to reduce the risk of infection quickly, but maybe not sufficient enough to block that reinfection, but ultimately enough to protect us, adults, from experiencing severe symptoms. And this is probably a very likely scenario because we know of at least 4 endemic coronaviruses that have followed this evolution. But with regards to SARS-CoV-2, there are many factors there, including the emergence of mutants. Only time will tell us whether we can totally forego all that social distancing restrictions and mask mandates. The lesson that we can see from countries that probably were quite happy that they had high levels of vaccination, where there was resistance for mask mandates, you can see that in communities or states, like for example in the US, where the vaccination rates are low and the use of masks and social restrictions have been eased, there has been a rise of COVID-19 infections. And what's also worrying is that you're seeing children and younger demographics being infected with the mutant strains. So no, an endemic does not mean that we are comfortable. An endemic just means that we are in control. And that control is highly dependent on our own behavior and the policymakers' ability to provide the resources to accommodate that behavior.
So it could also take it could also go into a path where things get worse.
Absolutely.
In that sense as well.
Absolutely.
Mm-hmm. Now, you mentioned something about the high cases that we have today, and I think that's something that we're observing now. That's something I want to kind of focus on, because when news of the vaccines were out, and as we got to understand the virus a bit better, we were told that with vaccines things would be better. But why are daily cases higher than ever, still really high even to today, even though many have received at least one dose of the vaccine? What's going on here?
Yeah, you're right. I mean, a lot of people ask me that question, and we will talk about vaccine efficacy. But let's talk about these higher numbers first. High numbers can really mean two things. First, we are testing more, or the number of cases have really increased. And I think in the case of Malaysia, I think both are true. And the main reason the number of cases are high is partly due to two factors. First, we certainly failed to contain some of the outbreaks that occurred effectively. But the reality is also the emergence of the Delta variant, that we are not only seeing this in Malaysia, but the Delta variant is now the most prevalent strain in many countries, including the UK and the US. And the recent data that was released by the Ministry of Health, based on genomic analysis done by researchers in Malaysia, does indicate that the Delta variant is probably the most prevalent strain circulating in our population now, replacing the Beta variant. And so why is this Delta variant so dominant? The first, it's quite evident that the risk of infection of the Delta variant is higher. The variant is twice as transmissible as the original strain identified in Wuhan, and 40 to 60% more than the Alpha strain. Second is the risk of disease severity is potentially higher. Because of the increased risk of infection, the viral load that is found in these patients appear to be higher. For instance, in the airways of infected COVID patients with the Delta variant strain is higher than those of other variants. And we know that an increase in the amount of virus in your body is going to increase the risk of an individual developing symptoms. So the question is then, why do we have this emergence of mutants? And that is because viruses have the ability to evolve itself by modifying its genetics. And it's not like the virus is really smart, but it's just a case of accidental evolution. As we now know, viruses need the human host to propagate. And as the virus enters into our cells, it hijacks our protein-making machinery to make more copies of itself. And as it replicates in our cells, it makes more and more copies of its genetic material. But as it is making more copies, it sometimes accidentally makes typos in these copies. Most of the time, and luckily most of the time, these typos either have no effect, or it actually makes the virus less viable, or the virus just does not become a virus, and therefore it basically is no longer going to be in the system. But on occasion, these typos create and confer greater survivability, infectability, and transmittability. So you can, I guess, see it as these mutations conferring superpowers to this virus. Of course, a superpower that we don't want. And that is why this Delta variant becomes the dominant and prevalent form, the survival of the fittest. And at this moment in time, the Delta variant is the fittest. And it's the fittest because the mutations that the Delta variant has acquired is all located in the gene that encodes that spike protein, which is the target for our vaccination, as well as how the virus enters into our cells. And these mutations increases the ability of the virus to stick onto the cells because it affects what is called a receptor binding protein. So now the virus is thought to be able to stick much easily. And when it sticks very easily, now it's going to be very hard for it to detach. And its ability to stick is compounded by another mutation in the furin cleavage site, which increases now its ability to go inside the cell. And sticking and going into the cells are key for a virus to be infective. And now you have these mutations that are conferring that accelerated and higher abilities. And I guess most of us are most concerned because this mutation is also located in what is called an N-terminal domain of the spike protein. And that's the domain where a lot of antibodies are thought to be very effective. And the recent studies have shown that the Delta variant, although, and I think it's important to appreciate and be a little relieved, is still susceptible to the antibodies that we produce during vaccination. It was almost 3 times less susceptible as compared to the original strain that were identified in Wuhan. And although antibodies were present, it is important that there was impaired binding and neutralization of this Delta variant. But what is really important here is that a virus can only replicate if it has a host. And that is why you and me, especially those of you who have vaccinated, you have really made a significant effort in preventing infections. Because the longer the virus is in the population, the higher the risk of acquiring new and more dangerous mutations. Over to you.
So what we essentially need to do is, and this speaks to vaccine inequality as well. So as long as there are people who are still not, or groups of people who are still not able to access vaccines, and the longer that this drags out as it becomes endemic, we are just there's a likelihood that we're just going to see new variants that could, I guess, lead to breakthrough infections, even though you're vaccinated.
Absolutely. And I think that's really why, right? I think there's this big concern if the vaccines that 60% of our Malaysian population has obviously been given, are they still effective or as effective as we thought? So it's still a relief with respect to the Delta variant. All current vaccines which were developed based on the Wuhan strain, right? And that's the vaccines that we have now, are still effective. But they do show a loss of efficacy in preventing symptomatic disease with the Delta variant. And we have results of a recent UK study which showed that both Pfizer and also the AstraZeneca COVID-19 vaccines, although they are still effective against Delta variant after 2 doses, the protection that they offer wanes with time. And at this juncture, the results show that the effectiveness of these vaccines reduced by about 10% after 3 months of vaccination. But the benefits of vaccination is still pronounced, because the UK data, and these are recent data, shows that there is still 75% efficacy in preventing hospitalization due to infections. The Israeli data, recent data, is also showing that these mass vaccinations also protect children under the 16, especially after 2 doses. And my colleagues in hospitals across Malaysia tell me the same thing, that they are seeing significant reduction in hospitalization, especially in Klang Valley. And the vast majority, if not, almost all of cases are individuals who have not received both vaccination or completed, both vaccination and 14 days after the second dose. So I think it's very encouraging, with more data as promised by the Ministry of Health as part of his manifesto shared yesterday, that with the Ministry of Data committing to be able to promote greater transparency in data sharing, hopefully we will get greater granularity, so that rather than the data that we have now, which just says, whether an individual with history of vaccination, hopefully we'll get more data about what actually is that history. Is it a single dose? Is it 2 doses after 14 days? What kind of comorbidities are we actually seeing? And I think with that data, we will begin to see the same patterns. And the reality is that I do not expect our data to be any different than what is being seen in other countries. And I go back to the same thing, and especially with COVID-19 vaccines, we all have this, I guess maybe it's hopeless optimism, that we feel that, when we talk about vaccine efficacy, it is sterilization efficacy, which means that you have no risk of infection, you have no risk of anything. But it was very clear from the start, based on work done in flu vaccines and all other vaccines against coronaviruses, that these vaccines are not 100% effective to stop you from getting another infection, because there are many other individual and viral factors that determine its effectiveness. But what is very clear, even though we can be maybe pessimistic about its effectiveness, do not confuse yourself by thinking that it is less effective than not having, or it's not useful to have it. It is certainly more effective than not having it. But it is certainly also not the sole solution to this pandemic, and also when we are in endemic. We need to have a combination of things. And the models that are being developed out there, and there's a latest model by Imperial College London, shows that even if the vaccine is 90% effective, we will need to reach at least 55% coverage to achieve, what is called perhaps, temporary herd immunity. But you would still need some social distancing measures, such as face masks, and also, work from home arrangements and social distancing. And with the current Delta variants and other variants that are actually coming out, I suspect that we really need to increase that vaccination levels. The more individuals are vaccinated, the greater the coverage of vaccination in the country. The reality is that it will correspond with how much we can open up our economic sectors and also reduce the restrictions that are actually out there. So we have to continue practicing all the key prevention measures, which I think Malaysians have been fairly compliant, so that we can complement the protection conferred by mass vaccinations.
But is herd immunity still possible with the Delta variant? And also new emerging variants that may be more infectious.
So if you talk about the conventional idea of herd immunity itself, perhaps it's not applicable when it comes to COVID-19. Because we have seen how antibodies naturally acquired through infection does not really make you immune to the virus, right? And many people have what you call as breakthrough infections, where they have reported getting second infections. And we also know that through the vaccines, where there are some individuals that develop symptoms and are positive for COVID-19. So when we talk about herd immunity, maybe we need to think about immune to what? Is it immune to the virus, or is it immune to protection against becoming seriously ill? And I think we should really be focusing on herd immunity in the context of the significant morbidity and mortality that the virus causes. So it would be very different than perhaps your measles and smallpox, definition of herd immunity. And is herd immunity in the context of immunity against the severe outcomes possible? The answer is yes. But of course, the exact percentage of a population that needs to be vaccinated against COVID-19 to achieve herd immunity against severe disease is still a point of scientific debate. Generally speaking, the more infectious an illness is, the higher the percentage that needs to be vaccinated. So now with the Delta variant, obviously we would need a significantly higher vaccination coverage. And that proportion of the population that must be vaccinated against COVID-19 to begin herd immunity, I guess, will remain unknown until one of these countries achieve that. But remember, how good your vaccination strategy is now also dependent on all the other public health strategies, as well as your own choices of behavior. And I think this is really an important area of research and will likely vary according to the community. And the vaccine is also a big question mark. I think over time we will understand how different vaccines may work differently. The populations that are prioritized for vaccination, how we have actually chosen to do that. And you can see, right? A year ago, we were not concerned about children, but now we are becoming more and more concerned as we see more and more cases. And there are probably a lot of unknown factors. But we also know that the coronavirus that causes COVID-19 is incredibly infectious. And because the Delta variant is being more transmissible, the trajectory of this pandemic is still so unpredictable, meaning even higher numbers that we originally thought will have to be fully vaccinated to achieve that sort of herd immunity. There's some scientists that are suggesting that for Delta, we need to have a coverage of up to 88% before we can achieve a semblance of this herd immunity. And let's face it, I think not many countries are going to be able to achieve it because of challenges such as vaccine distribution, vaccine hesitancy, and hopefully we don't have that problem of new mutants that might come up and undo all that good work. So for me, it's important when we talk about herd immunity, let's talk about herd protection. And I think that's a more realistic concept. The key is to get as much of the global population vaccinated as quickly as possible. As many of your neighbors and people around you, including younger age groups like the 12 to 15-year-olds, it is really important that government start strategizing. I know that the priority and the prioritization also depends on vaccine availability. But when that's not an issue, we really need to make sure that we increase the coverage of vaccination as quickly as possible. Because it really makes sense that those vaccinated will manage to fight off the virus, and due to the vaccine-induced antibodies, before it has chance to divide and multiply inside, the viruses can be stopped. We can stop the viruses from spreading itself. And it may be just like the flu viruses and the flu vaccines that we have. The herd immunity is not the primary goal, but rather the maximum population protection through the vaccines and public health measures. The priority should be about how best can we protect people from serious illness, prevent healthcare systems from being overwhelmed, and most importantly, and I think for many of us, minimize the disruptions to the socioeconomic activities. And that's the protection that we need.
I want to take a segue here because I'm just looking at the comment section. There are people who are talking about, aside from just vaccinations, alternatively to vaccinations, what they could do to reduce the spread. And then there are people, as Wailing Liu points out here, there are people who claim as long as they are healthy, exercise daily, and consume organic food, that they do not need vaccination. Is this true? And then we have another commenter that says, if they could control some kind or have habits or take medication that can control the inflammation in the lungs, would that also help, aside alternatively to getting vaccines?
Yeah, so I guess the question of organic and behaviors and actually trying to prevent, right? First of all, I just want to say, especially in the battle against COVID-19, there is really no alternative to vaccination. All right. You should see the whatever measures that you are suggesting. I'm not suggesting that trying to control inflammation, trying to live a healthy lifestyle, trying to eat healthy. I mean, all of these things will certainly improve your chances of recovering from an infection. But you must not see it as an alternative. You must see it as something that is complementary to vaccination. There are many people who would argue that even natural immunity, I'm fit enough, I can fight it, because if you really get sick, you will develop a bigger antibody response, and your body, if you're strong enough, you can develop antibodies and the memory to all of the surfaces of the virus and not just the spike protein. But it's really a very romantic theoretical notion that natural is always better. Remember that, there are lots of natural causes of death. And you have to remember that the natural risk of COVID-19 infection, and we are seeing that in hospitals among young individuals that don't have comorbidities, suffering from severe hospitalization, long COVID, and death. And that is the natural risk of COVID-19 infection. And that is the risk that you're taking when you want to acquire natural immunity. So it's really important to appreciate that vaccination is the strongest possible available strategy, besides maybe just covering yourself in a bubble and never meeting anybody else, to stop yourself from actually suffering from all the severe complications. And we must be able to stop looking at things in a black and white thing. Just because there are individuals that have been vaccinated who might have developed symptoms or severe symptoms, it does not detract from the fact that you have lowered your risk. It's the same thing. Just because there are individuals that drive cars while they wear safety belts, die in accidents, it does not mean that safety belts does not prevent deaths. It just means that there are other confounding factors, such as the speed of the car, right? And the instances in which that accident happens, much like maybe the load of infection was much higher, maybe that there were underlying factors that made that individual suffer, the time in which he or she went to seek for medical attention. All of these determine an individual's ultimate outcome. So while I think it's fantastic, in terms of living healthy, eating food that is devoid of pesticides and all the other things, do not think that it's a substitute to, very clear evidence that vaccination works in helping to contain the disease. Just because the number of cases at the moment are high, it does not mean that those vaccinations haven't worked. When you talk about 60% of our population have had at least one dose, what does that actually tell you? It means 60% of the population has been vaccinated. It also means that at least 12 million people in this country have not been vaccinated. And when you talk about category 4 and 5, that's still 12 million at risk. And that's the kind of data that we are seeing. So it's really important to put this in context. A reduction in risk doesn't mean that zero risk, but an avoidance of it is going to put yourself at significant risk of infection.
But from what we know is that once you have been infected with COVID-19 and you recovered, you do have what you call natural immunity. You do build up natural immunity. So why should people who have been infected with COVID-19 and have recovered and probably do have some kind of level of natural immunity, why do they still need to take the vaccine? Aren't they already, don't they already have antibodies that should last for a while and protect them from the virus from being reinfected again?
Yeah, that's a great question. And again, it's how we actually interpret the data that's out there. True, you can develop natural immunity, but there's also a lot of data that comes out that 1/3 of individuals that contracted the virus and were hospitalized and then recovered did not develop a strong enough antibody response. In fact, detectable antibody response. Another 1/3 of individuals, within 3 months, their antibody levels had dropped to a level that was undetectable anymore. And only 1/3 of those individuals were able to mount a strong antibody response. And which is why over the course of a year, we have seen how individuals who have contracted and suffered from symptoms became ill again a second time due to repeated infections. And so, although there are going to be individuals that will have higher levels of neutralizing antibodies, the decline of these antibodies and the fact that there are 1/3 of individuals that don't develop enough of this antibody response suggests that the immune response that comes from a naturally acquired infection is not sufficiently uniformed. And that is exactly why an effective COVID-19 produces a more controlled, robust, strong, and long-term adaptive immune response for the majority of individuals. And that proven data of preventing serious adverse outcomes cannot be substituted by natural immunity, which is also why even individuals who have a history of infection is recommended to be vaccinated. Right? So you have to understand that if a new infection fails to build your ability to develop the memory B cells so that your body is able to manufacture the antibodies if you are going to have a second infection, then unfortunately, you're going to be at risk again.
Now, I want to go to one of the questions that one of the commenters has put up. Does a person who acquire more than, on the topic of vaccines and antibodies, does a person who acquire more than 150 measurements over there, U/ml of COVID-19 antibodies is protected against getting infected with COVID-19? And this brings a lot of other interesting questions about, how do we actually know how many or how much antibodies that we have and whether we should get tested in this current state in Malaysia as the daily cases are pretty high. Would you encourage a testing of antibody levels after being vaccinated or just maybe after you recovered?
Yeah, so that's a great question. I can understand this allure of wanting to know if you have actually acquired the ability to develop these antibodies against SARS-CoV-2 virus after being vaccinated. But I think it's really important that you understand that the tests that are actually available in the market today can confirm certain things, but it also cannot confirm many things. And this is the exact reason why the regulatory authorities like the US FDA and also the CDC recommendations do not recommend this test to be used to evaluate an individual's immunity against COVID-19. And this is because of two factors. The first is the reliability of these tests. There are quite a number of antibody tests on the market. And the reality is that the type and range of the antibodies that is actually being tested vary across various different tests. And as a result, the ability to accurately detect the levels of antibodies in your body at a given time varies considerably. So the specificity is really not accurate. And so there's a moderate to high risk of false positives or false negatives. So if you test, oh, I can detect antibodies, you are still not sure whether you have actually detected the right antibodies. Or if you actually get a test to say, oh no, you don't have any antibodies against SARS-CoV-2, you're quite not sure whether the test falsely gave you a negative result. And this is really disconcerting. The second is the test. What is it actually testing? First of all, right, this test only predict the levels of certain types of antibodies. But antibodies alone do not accurately reflect your immunocompetence, your ability to mount an immune response, especially when you have a real infection. And you have to think about the immune system more than the antibodies. When we talk about our response against COVID-19, we talk about what is called an adaptive immune response. And this adaptive immune response is complex. It involves the interplay of different types of cells and factors that are not captured by this antibody test. Another important thing is that your antibody levels today will vary day after tomorrow or in 2 weeks' time, because these antibody levels rise and fall at different times. And our body reacts to these vaccines differently. And so the timing in which you do this test also is going to be very, very critical. So really important for you to understand that your antibody test does not really measure your ability to develop a T-cell response, which is also very important against viruses. The ability of your memory cells, that when there's an infection, because those antibody tests don't actually measure that. So apart from satisfying curiosity, I would actually tell you that because of the lack of robust scientific evidence to support the suitability of these tests as an effective measure of immunocompetence, I would not recommend anyone to undergo these tests, especially if the primary purpose is to only find out if you have developed effective immune protection against COVID-19. Because even if there is antibodies, you don't actually know whether the antibodies can target. Even if you don't have antibodies, you don't know whether when you actually have COVID-19, whether you will actually develop those antibodies. So for me, it's really, really important. And I'm glad you have actually asked this question. I'm sorry, I don't know who you are. If not, I would have addressed you. But it's really, really important that we are aware of the limitations of this test and the danger when we wrongly interpret this test.
Thanks for that, because right after we had that question, there was another netizen that commented on the same thing as well. What, whether a test is recommended and what's the best time. So again, maybe if we can recap, what you're saying is that it is not. It doesn't really give you a good. Doing an antibody test doesn't really give you an accurate picture of your immune system response towards COVID-19.
That's right.
Okay. Now, I want to come back to a previous topic you talked about. In order to so-called reduce the number of infections, in order to reduce the emergence of new variants, and to stop, or maybe to reduce the hospitalization rates and death rates, we're talking about wanting to get as many people as possible to be vaccinated. But then there's also another discussion of breakthrough infections, and how there's a discussion on maybe we need more than just 2 doses of the vaccine. Maybe we need probably a booster shot. What are your thoughts on that? Do you think we need an extra dose of the COVID-19 vaccine as our country moves towards this endemic phase?
Yeah, I think it is certainly something that we need to start planning, so that when we are actually ready, we certainly need to be at the forefront in providing these booster shots. These booster shots, booster shots are essentially the same doses as given in the 2-shot regimen or 1-shot regimen, depending on the type of vaccine. But this extra dose mobilizes your body's immune system to be able to even enhance its protection against COVID-19. And because these booster shots will be designed, these vaccines will be designed against now information about these new variants such as Delta, they would certainly provide greater confidence on its efficacy against these dominant strains that are circulating at this juncture. And the recent trials that were conducted by Pfizer, suggest that these booster shots, given at least about 6 months after the second vaccine dose, does produce antibody levels and protection 5 to 10 times higher than after 2 doses. And the single dose Johnson & Johnson published some data last month to show that the antibody levels increased by about 9-fold in individuals who received the extra dose. And they found that individuals that had a third dose of Pfizer vaccine also showed a significant boost in its immunity. And the recent data, even though I don't have the exact percentage from AstraZeneca, is also showing that the third dose certainly boosts this. And I think when we think about risks, we know that booster doses are actually routine. We all, as we were growing up, received routine vaccination and boosters for our tetanus and diphtheria and mumps and BCG. And these vaccine series, as we call them, were recommended because at some point we need to develop and to ensure that the memory cells, which are essentially our internal immune memory, so that if there is infection, we are able to mount an immune response, is there for a longer period of time. But you bring up a good point, and I think this is very, very critical as we push for third doses. Where are these variants emerging? And that's the biggest threat to even the protection that we already have. And that's emerging from individuals that haven't been vaccinated, from populations that are under-vaccinated. And so, Joshua, you mentioned the word vaccine equity just now, and I think it's really something that we have to think about it. Nobody is safe until everyone is safe. And it's not just a rhetoric cliche. We got to focus on getting everyone around the world safe. Because if we want to avoid the rise of new mutants, we got to make sure that these are the groups that get their first and second dose of vaccination first. Only then can we make sure that, for example, countries like Malaysia, who has done a great job to get us to 60% now, we don't undo all that if a variant that can evade all vaccinations and all immune systems, arises. So it's really important that we start preparing to be able to provide these extra doses and boosters and prioritize it based on individuals who are already double vaccinated. But we must not detract ourselves from the first agenda, which is that we need to mobilize these vaccines across the world and ensure all are vaccinated, including in Malaysia, as we know with the Delta variants. Let's not be just happy with 60%. Let's try and push it up to 80, 90% and be really proud that we have come together to reduce that risk. We also need to be considering about cost, but I will assure you that the cost of a single booster dose will still be cheaper than the risk of a full-blown epidemic or pandemic that's caused by a variant that goes rogue.
Yeah, the hospital bills are not something to laugh about. I see a couple of follow-up questions, and it's kind of interesting over here. We'll get to those really soon. But in the effort, again, aside from, what I'm hearing is that let's not talk about the third dose. We can study it and we can prepare for it. But what's more important now is that we get more people fully vaccinated with the first 2 doses as well. And I think what our government is currently studying as well is the need to vaccinate teenagers.
Yep.
And maybe down the line as well, people below the age of 12 years old. But could you, what can you tell us about teen vaccinations or vaccinations towards a younger age group? Is it safe and is it necessary?
Yeah. And the answer it's yes and yes. It's certainly safe. There's no reason to suggest that it's not going to be safe. Um, Last year, when you're talking about the other variants, it seemed that, children were at a lower risk. But the current latest data is suggesting that although maybe the latest UK data suggests that children are not more prone to long COVID as much as adults, they are about equally the same. There's no statistical difference. But we are seeing increases, and you can see in states like in Louisiana, and we are also seeing cases in Malaysia where you have children who are becoming very ill and dying of COVID-19, which was unheard or relatively unheard. So it's really, really important that we recognize that the emergence of these mutants are also increasing that risk. And there are many adolescents, no thanks to our diets that we have, including mine, are also clinically vulnerable and live with vulnerable adults. So to the question of, do I believe that teens need to be vaccinated? Yes. The governments were right in prioritizing the older group, but I think it's about time when we think about the context of the variants. It's important that we certainly increase that. And in tandem, also make sure that the data that the Ministry of Health is actually going to be producing and releasing out next week, I'm really hoping that the ministry will stratify the data according to ages as well, so that we can actually make informed decisions rather than hunches.
Informed decisions like, as one netizen has pointed out, are there vaccines that are more suitable for teens, and maybe are there vaccines that are not? What have you, in your research, is there such a thing as a vaccine that's more suitable for children and
Yes.
teens?
Good question. I don't think any of the vaccines were established just for children's, but for children, because you understand that, the way the function of the vaccines, they are not really age specific, right? As long as, a child has the ability to mount an immune response, then the vaccines that are available, are suitable. And in fact, a handful of vaccines have been tested in younger people over the age of 12, including the Moderna and the Pfizer, as well as both Chinese vaccines made by Sinovac and Sinopharm. And other countries like United States, Israel, and China are also now even offering these vaccines to this age group. And you also have certain studies that have already been run, and we are now expecting more results, such as the one from India, the Zydalus Cadila vaccine and the Covaxin. So we have not heard of adverse reactions apart from that one potential link of Pfizer vaccine and heart inflammation. But again, the number of cases are really, really low. And I would like to remind people again about the whole, concerns everybody had regarding AstraZeneca and blood clots. The clear message here is that the benefit of the vaccination far outweighs any of the risk. And so far, the vaccines that have come out, the results that have been out, the vaccines appear to be safe in adolescents. And in fact, some companies have now moved to carrying out clinical trials in children as young as 6 months old. And it's thought that in the United States, vaccines for those under 12 might be available later this year. And when we think about how our poor kids, right, have been really suffering, not being able to go to schools and losing out on all that social interactions, I really feel very strongly that in the face of unfortunate, high risk of infections, it is critical that we use the data that's out there now to be quite comfortable in recommending for adolescents. And then as more and more data come for kids below the age of 12, we can improve. Because the important part here is because this whole idea of mutant variants, right? And remember, the mutant variants will also replicate in children. And because, right, there is a risk that more transmissible variants will develop a way to push through whatever it is in our young immune, response. There is a high risk that the variants emerging may become more resistant to infections, and therefore it makes a very strong case that the children also will need to be vaccinated.
Thanks for explaining that. So, as part of the Q&A session as well, and part of the previous topics that we talked about, someone has asked about our discussion just now on testing antibodies, and now they're asking, without tests, how will we know if the vaccine is working?
Yeah, one of the reasons why people want to get tested has always been the fact that, especially in Malaysia and a lot of Asian, individuals, and maybe just human curiosity, we always want to test. How do I know I'm good at maths? Only if I get an A. That's why I know I'm good at it. In the case of, this whole idea of vaccination, right, and what it is, right, because it is very clear, right, vaccination alone is not sufficient. You need to have all these other complementary layers, such as, wearing a mask and, ensuring that the public health measures bring down the risk of infections to a level, that is sufficiently low. The question is not so much how do I measure, but ask yourselves, why is it really important to measure? The question should be about how can I actually reduce my risks, and how can I maybe encourage scientists to come up with better tests? If there was a good enough test that can actually tell you how immunocompetent you are and tell you that your result, when it's positive, when it's negative, and therefore go and get a booster shot, it's a reliable test, then it is worthwhile getting tests. So when I'm suggesting, and questioning the need for testing, it is not because I feel that you should not satisfy your curiosity and there's no value in testing. I'm just alluding to the reality that the current tests are just not sufficiently reliable to give you an actionable response. And because you can't really do anything with that test, I call into question, what's the value of that test? But I'm really confident because there are so many researchers and so many teams that are actually trying to improve that test. There's so many studies that actually been done in many different universities to actually try and see how can we improve this test. Much like how we have improved the ability to detect our viruses. In the past, it's whether the virus is positive, or negative. Now we also can identify the strains, we can do whole genomic sequencing, and we can be more specific and be able to provide, more detailed information. I seek your patience that until we have this reliable test, please question its utility.
Follow-up question to that then, how did the scientists, you talk about like it's not the test that we have so far is ineffective, but how did the scientists know the level of antibodies developed after each vaccination and booster if there were not any antibodies tests done?
Yeah, so you must remember that the data that actually is coming out from the research labs, right, are very different from the data that's actually coming from a single test point. The research labs undergo multiple different tests. They don't use a diagnostic test. It actually goes through very complex experiments to actually test every single subpopulation and different type of antibodies, and takes a lot of painstaking analysis that will not cost 100 ringgit or 200 ringgit. It will cost a few thousand ringgits, and it's also highly sensitive to be used for a diagnostic purpose. So it's a very, very good question. The question is, the test that you actually do in the market, is it the same that's actually being used in research, where they actually also calculate the size of the cells, the morphology of the cells, to identify how many population of B cells, T cells, memory cells, and that actually gives you that confidence that the kind of antibody measures are accurate. And it's also a time course measurement, not just measured on a single day. When we talk about 14 days after vaccination, that is an average response. It does not allude to that for some people, it might be the 13th day, it might be the 16th day, it might be the 17th day. And that is why it's important to recognize that we transition to an endemic. It does not mean that our behavior on the 14th day should be any different than our behavior on the 24th day or on the 34th day or on the 140th day. Our behavior is going to be dependent on the environment that actually we live in.
iPhone Low asks, what is your comment on taking mixed vaccine on third dose?
So the data, there's some data that actually shows about the use of mixed vaccinations, and there's no suggestions that it's not a bad idea. At this moment in time, the few papers that have come out didn't talk about the third dose, but it was actually mixing of doses in the first and second. They found that it was similarly effective, but there was some side effects, but they were transient side effects that was of very low concern. But I think there's going to be value, especially if the booster doses are going to be targeting these new variants. Because remember, all the current vaccines that have been administered targeted the original strain that was identified at Wuhan. So I'm quite certain when the booster shots are actually more prevalent, and by the time it reaches our shores, I would not be surprised if it's going to be a combination of vaccines. But as we know, the decision to import our vaccines is also a very interesting, not just on a scientific basis, it's also geopolitics. It's important to diversify our source of vaccines, because if we are too dependent on one company or one country, you can realize that our own sovereignty can essentially be compromised, because there's something called vaccine diplomacy, and it's not very diplomatic. And so I really, really feel very strongly over time, and I think building capacity to also make our vaccines, and that could be a different conversation at some point, local capacity to develop those vaccines are also equally important. But to your specific question, I will be very surprised if there are no combinations of vaccines when the third dose and fourth dose of vaccines. I mean, think about flu vaccination that happens on an annual basis. The vaccine that you take is not dependent on the vaccine that you took the year before. As long as the vaccines are registered, it's safe, and it's focused on the particular variants and mutants at a given time, then it's the vaccine to take.
But is it safe to mix vaccines though? Because each vaccine has kind of their own set of side effects and complications. And if we mix them together, would that result in new complications and new side effects?
Yeah, as I mentioned just now, the initial data of mixing vaccines suggests that there might be some transient side effects. And this, you're talking about things like fever and pain rather than more serious side effects. The one thing important is, when all of us are vaccinated, those vaccines are no longer in our body, after a couple of weeks. What we have is actually our own immune cells that have actually developed, an immune response ability to fight against, COVID-19 viruses. So when a new vaccine is brought in, it's not going to say, hey, this is not a vaccine that I've never taken before. It will look at it as, hey, that's the spike protein, and the spike protein is shaped slightly different. Oh, okay, this is an antigen and I need to target it. And because it's a different, slightly modified antigen, independent of the type of vaccine, there will be a mounting of an immune response. But the question on safety, science tells me that the risk is very low in terms of combining vaccine. But I might be wrong. But I'm confident that our Malaysian NPRA or any regulatory agency will not suggest to mix vaccines unless there's actually clear evidence that it's safe and efficacious.
All right.
And I think the third booster dose will be very similar to our current, delivery of our doses. That, we will not be able to have the choice of the vaccine, but essentially it's the first vaccine that we get will be it. I imagine so, at least for the third dose. Maybe the fourth dose, things would change.
the government has recently announced about the ceiling price for self-testing kits as a way to improve detection of COVID-19. But how reliable are the self-testing kits?
Yeah. So the self-testing kits, much like the antibody test, but in terms of reliability, it's still better. But they do have their limitations, and I think the data that's coming out in the UK, for example, that encourages self-testing, what needs to be very clear is that there is a high false negative rate. So you might be positive, but it might come out as negative, or vice versa in some instances. But the self-testing kits are very critical public health strategy to a certain extent, cost being put aside, because it actually reminds people that we are in an endemic, and the fact that people consistently go and get tested, and if we can modify behaviors towards actively testing, you will find that the kind of choices that put us at risk of infection also reduces. So to that very, very good question, depending on the type of test that's actually available, and I haven't done a direct comparison between the tests per se, so I can't really compare. They are not as specific and sensitive, especially against diagnosing, for example, RT-PCR, but because they are more cost efficient, they are more cheaply accessible, and because we are moving towards responsible self-isolation, even if it has a 70% sort of sensitivity rate, I would still recommend it, because then you take it. But to a certain extent, if we are able to be responsible enough, if we know genuinely that we are a direct contact of an individual, independent that we are symptomatic, and if we are able to truly work from home, then it is certainly something worth asking. Do we need a test to modify our behavior, or we can actually afford to take that 2 weeks and restrain ourselves from exposure?